So in the last few minutes, we're going to talk about part 3, last 5 to 10 minutes, and then we'll have some more questions. This part 3 is the investigational part. This is clinical research. This is not ready for prime time. It's not considered standard of care. And this is the ability to just do focal therapy to treat prostate cancer. So why are we looking at this from a research standpoint? Well, it turns out we understand a little bit more about the natural history of prostate cancer, especially something called the index lesion. Secondly, I've already shown you that this new type of MRI is really good for finding tumor suspicious regions. And when we find those tumor suspicious regions, we can biopsy them under MR guidance. It turns out using MRI, we have a way to monitor the temperature inside your body real time. So if I put a laser in your body and start cooking a tumor, I can actually watch that real time with MRI. I can just cook the tumor, fry it, and make sure I don't hurt anything around it. That's called MR thermometry, or MR thermal imaging. Turns out there's a laser that's got FDA approval for treating prostate disease. And then, you may have heard of continuity of care, where one physician kind of follows a disease process all the way through. Well, I also talk about a continuity of imaging story here, where we use the same MRI to find the tumor suspicious region, then to do the MRI guided biopsy, and then to guide the focal therapy of the prostate cancer. So what's driving all of this? Well, if you think about it, the prostate gland is the last place where if you get a cancer, no matter what, we treat the whole gland, right? If you have a breast cancer, it's highly likely you're going to get a lumpectomy, right? If you have a lung cancer, they may just remove the segment that has that lung. If you have a metastasis, just one that goes to your liver or goes to your brain, they can go in and just remove that part of the brain or just remove that part of the liver. But in 2012, the standard of care is if you have prostate cancer, they remove the whole gland or they radiate the whole gland. Well, we're starting to rethink that, saying, well, hey, maybe some of these prostate cancers, we can just treat the cancer and leave the gland in there and not give the guy erectile dysfunction or urinary incontinence, okay? So whole gland therapy consists of radical prostatectomy, that's surgery to remove the gland, all different kinds of radiation therapy. Brachytherapy is seed implant placement. There's external beam radiation, intensity modulated radiation. At Loma Linda, they have something called proton beam radiation. These are all just different ways of radiating the whole gland. Then there's also hormone therapy. Now we're looking at focal therapy where instead of treating the whole gland, we just use these different energy sources. We can freeze it. That's called cryoablation. We can use high-intensity focused ultrasound. That's called HIFU. There's radio frequency ablation. And then what we're using here in the desert is laser ablation. And what you're going to see over the next 2 to 5 years is a trend towards what we've done with breast cancer, where now you get a lumpectomy and some radiation therapy instead of whole gland therapy for a subset of patients that have breast cancer, in the case of breast cancer, but also we think a subset of men who have prostate cancer. Now, what's driving this? What's driving the interest in focal therapy for prostate cancer is whole gland therapy's morbidity. Morbidity is bad. Okay, those are the side effects. Those are the things where we're trying to do no harm, and in fact, we end up harming. Okay? So erectile dysfunction from radiation therapy or from radical prostatectomy occurs up to 50%, 50, of the time. Urinary incontinence occurs up to 25% of the time. Hormone therapy side effects, those are some of the worst side effects. I mean, when I talk to a man who's on hormone therapy, they basically have kind of a chemical castration. And they go through something that's like what we call male menopause. Now, the reason that urologists have not developed focal therapy prior to this was that they've known for over 25 years from studies done at Stanford, in fact, while I was there as a resident, that prostate cancer is multifocal 80% of the time. That means it's in more than one place in the prostate gland. So if that's the case, how can you only treat one focus of the cancer? Because it's in other places, right? Well, the reason that we can just treat the one focus is it turns out 92% of the time, it's just a single index lesion that is the bad actor, okay? The index lesion is the largest focus of prostate cancer with the highest Gleason score, okay? Well, you might say, well, how the heck do you know that? Well, there's a study in Nature Medicine. Nature Medicine is a very high-profile basic science journal. in which some smart guys and women got together and they studied the DNA of metastasis that had killed patients. Okay, these are in cadavers. They went in there, they studied the DNA, and they compared the DNA of the metastasis that killed the patient with the foci of cancer in the prostate gland. And what they found was when you compare that DNA, 92% of the time, all of the metastasis came from one place in the prostate gland. Only one of the cancers in the prostate gland. And the one that they came from was the largest, highest Gleason score focus. And they named that the index lesion. Okay? So now you've got this index lesion concept, and there's a guy, Dr. Ahmed, who's a urologist at University College in London, who wrote a very provocative article in the New England Journal of Medicine, one of our highest profile journals, talking about the index lesion and the origin of prostate cancer. And this is an artist picture from that article. And what it talks about is, yeah, prostate cancer is in more than one place in the prostate gland 80% of the time, but only the largest, highest Gleason score focus spreads into the bloodstream, spreads to the bones in the body or lymph nodes in the body, and ends up killing the patient. So it turns out that even though prostate cancer is multifocal 80% of the time, since 92% of the time this index lesion is the one that's biologically significant, focal therapy may still be appropriate because we can use MRI, we can find that largest, highest Gleason score tumor, biopsy it, prove it, and then we can treat that index lesion and not worry what's going on in the rest of the gland. After we treat that index lesion, you just get an MRI once a year. If something else starts getting bigger or starts looking aggressive, then you can treat that. So our goal from a research standpoint is to convert low-risk prostate cancer, like 3 + 3 = 6 or 3 + 4 = 7, into a chronic illness where you come in, have your MRI, we biopsy anything suspicious. If it's a low-risk cancer, we go in there and laser it and send you on your way. And 3 or 4 years later, if that comes back, we laser the new focus. So you die with your prostate gland, you die continent, you die with erectile function, but you die of something else because we just focally treated those prostate cancers as they picked up. That's kind of the vision for focal therapy. So this is the device we use. It's just a little laser. It sits on a cart that's only about this big on wheels. It's really simple to use. This is the little interstitial diode laser that we insert transrectally using that same endorectal needle guide. Here's that little endorectal needle guide. Like I said, it's about the size of your index finger. It's got this heat diffusing tip so we can just heat up tissues right at the tip of the laser. We use that same device, that Dynatrim, to place the endorectal needle guide, and we insert the laser through that. So here's the patient's artist's view of the prostate gland. This is the laser placed in the prostate gland through that endorectal needle guide. And then these color images are a way that we can use MRI to monitor the laser therapy real time while we're treating the patient. So this is the first patient that we did. This was a 72-year-old male. His PSA had made it up to 13. He had a trust biopsy that showed low-risk prostate cancer, 3 + 3 = 6. But he knew that he had low-risk prostate cancer. He didn't want to have a radical prostatectomy. One of his closest buddies, I think it was even best man at his wedding or something, had a radical prostatectomy, and he was both incontinent and had erectile dysfunction, both. And this guy said, look, I don't care if this is investigational, I'd rather die with my disease than deal with what my buddy's going through. So he came in, we did an MRI, and on the diffusion-weighted imaging, the Gleason score 6 cancer, which we knew was back here, we didn't see well. Didn't show up very much because it's not very aggressive. Instead, though, this more aggressive tumor suspicious region showed up. It's dark here, it's bright here. On the contrast-enhanced images, notice these red areas. And we biopsied that under MRI guidance. Here's the confirmation scan showing the needle in the prostate gland. And this turned out being Gleason score 3 + 4 = 7. So more advanced prostate cancer than had been picked up with the trust biopsy. But he still elected to go on with focal therapy. So a couple years ago in an outpatient setting, just using some happy drugs, this guy walked in and walked out from his cancer therapy. So this is the laser probe placed. This is, looks a little bit like a weather map, I'm sure to you, but that's the laser probe in the prostate gland. And these are those real-time temperature map images. The first thing we do is we heat up the tip of the laser to a febrile illness, to just like 104 degrees, so we don't hurt anything. And we look for the color to show up so we know where the tip is, to confirm it's where we want it to be. Then we actually heat it up to a kill temperature, which is 60 degrees Celsius. And that's this yellow that you see here. Notice how it starts out in this yellow area, grows with time. That's the irreversible damage estimate. That's where we've actually destroyed tissue, okay? So after we destroy it, that's called coagulation necrosis. We basically just fry it like with a lightsaber in Star Wars kind of a thing. We give some contrast, and the area that we've destroyed doesn't enhance at all. It's black here. That's the prostate gland. There's that endorectal needle guide. There's the little laser probe, that skinny little black line still in place. Here's the diffusion-weighted image that showed the cancer before we treated it. There's the irreversible damage estimate image. The yellow is where we destroyed the tumor. And then there's the necrosis that doesn't enhance at all, showing how they correspond exactly in size and shape and location with the biopsy-proven cancer. We brought the patient back a couple days later and re-imaged them. On the diffusion-weighted image, on the ADC map image, there was a dark area here. It's totally gone. On the diffusion-weighted image, there was a bright area. That's gone. And on the contrast-enhanced image, there's a hole here. Notice the rest of the gland enhances a little bit, but here where we did the laser of the tumor, there's just a hole, like a Swiss cheese hole. And if we look at the enhancement curve there, you can see there's no enhancement at all. Okay, so we totally destroyed that part of the prostate gland. So in this research component of things, we've treated 14 patients in the last couple of years. We've had no complications. So nobody got any erectile dysfunction, no urinary incontinence, no infections. They've had no side effects or morbidity. It takes us about an hour and a half to 4 hours to treat a prostate cancer this way. And our goal is to get rid of that diffusion-weighted abnormality on the MRI. So it's just a small series of what we've done, but I wanted to show you that so that you can see that not only is the MRI good for detecting the prostate cancer and biopsying it, but in the future we may be using the MRI to guide focal therapy. So here's that syzygy and kind of the three-pronged approach that we have for an MR-guided program for prostate cancer. We can find it using the diagnostic MRI, we can biopsy with MR guidance, and then we can focally treat it with MR guidance as well. So when you leave here, I want you to kind of think of MRI as being kind of the GPS system for detecting and localizing prostate cancer. So hopefully if you were discombobulated about MRI of the prostate gland, I've taken you to the recombobulation area a little bit. This is a true slide actually from the airport in Mitchell Airport in Wisconsin. I'd be happy to take any more questions.